I'm going to move over to Michael now. Um, Michael, the article that you wrote for The Exchange, which we all thought was very interesting, looked at the risks faced by humanitarian workers, specifically medical staff in this case, working in MSF projects in the Yemen. And I wondered if you could elaborate on that. What is the security situation for aid workers, and are they being targeted at all by armed groups?
Well, I'll start by thanking ODI very much for inviting me to the 7 and also for publishing the paper that Wendy just mentioned. My intervention here will draw on a research that I led in Yemen last year on security of humanitarian staff and in particular medical staff. In particular, in the governorate of Amran, so a particular place at a specific time, and that has to be taken into account in our discussion. In particular, because MSF works in 6 governorates today in Yemen, in very, very diverse situations, responding to many different contexts and situations that have nothing in common. Through projects that are also very diverse, from HIV care in Sana'a to general secondary healthcare in the north of Yemen to surgical care in Aden, for instance. And of course, that means that the situation related to the security of aid workers differ very much from a place to another. And so that question that is quite simple in appearance is actually very complicated. And in addition to that, it has been evolving very fast. So the Yemen of today is not the Yemen of 2 weeks ago, and certainly not the Yemen of last year. But still, if we try to summarize globally, and I will then escape from globalization quickly, in the recent 2 years, MSF hospitals have been bombed. Recently, not latest than the January, the Adali Hospital, supported by MSF Holland, was targeted, and the activity was suspended for a couple of weeks there. There've been a number of intrusions by security forces in our surgical structure in Aden in the past 2 years, where the police or the military was looking for particular patients. We've had also raids from families of patients who were looking for families of, looking for somebody in particular. The last serious incidents in our hospital in Aden occurred in October, leading to a closure and suspension for a few weeks as well, and activities resumed early December after round of serious negotiations with all the stakeholders. But if you look at the total number of incidents that have been affected Yemen, or our project in Yemen, and those that we've particularly faced, many are not related to political violence. And I think that was one of the, let's say, highlights of the research. Most of them, at the time, found their origin in first a very troubled relationship between patient families and doctors, and I will come back to that. And then on the other hand, around issues of resources, access to jobs. And if I look at the situation of Amran Governorate today, with a complete change in the context, with a renewed conflict situation, it's quite interesting to see that the more violent politically the situation is, and the safer the teams are, in some kind of paradoxical way, but a paradoxical way that we can certainly explain, and I'd be happy to discuss further with you. I was mostly curious about that troubled relationship between patients and doctors, which was illustrated by heavy level of threats, a number of threats affecting doctors by patients. Patients being harassing doctors, complaining about doctors' behavior, doctors feeling that they were not protected in the hospital. And I found that it was a sort of a very common perception in Yemen that doctors are not respected. And why are not they respected? Well, it seems that doctors are not respected because they are considered either not competent and skilled enough. Sometimes they are considered crooks. And I think that something that Tron just mentioned is quite interesting. Yemen is a very, very poor country, and its neighbors are very, very rich. And so the expectations are very high. Expectation to medicines, towards medical care, are very high. And when Yemeni look at the quality of care in Saudi Arabia or Oman or Qatar or even Egypt and Jordan, they want the same. And they don't have the same. They don't have the same because the public services are in ruin in most places in Yemen. And the private care is out of reach, financially speaking, for most people. But the demand is there. And the situation for MSF is complicated as it offers services in places, it offers general hospital care in at a level that is sometimes contested by the population. There is a demand for top-of-the-range medicine, super high-quality care, and patients get easily nervous. There is, in this part of Yemen in particular, in Amaran, which is a tribal area, a way of dealing with situations like this and conflict, which easily takes the form of threats, of threatening behavior, of the people would intrude, enter in hospitals with arms and weapons. And we work with doctors that are often not from this area. They come from Sana'a, they come from the south. They are not always accepted by the community, and that creates tensions. On the top of that, I would say that MSF has a responsibility as a care provider in terms of organizing the care, in terms of making sure that the triaging of patients is well understood, in terms of making sure that the care that is available to the public is sufficiently communicated to the community so that they don't have expectation that will be disappointed. That, for instance, surgical and medical dossiers are of good enough quality so that we know how we've been dealing with a particular patient at any given time. And that is not always the case. So we see that in a situation where, as my colleague just said earlier, is very volatile and characterized by conflict. Conflict is not always at the origin of violence and insecurity, but what is at the origin of insecurity and stress and risk exposure for doctors is the way we do things, is our programming, okay? And that there is a very strong responsibility on the employer, on MSF, to address this particular question. There was, I did my research in July last year, and in the year before, there were 40 incidents recorded. Most of them were related to, again, like resources or in jobs and care. There's been much less incidents in the past few months, despite a surge in conflict. And one of the explanations that we can find, and it's only one hypothesis, is that the care we provide now is much more needed than it was last year, because people desperately need care, need to access a surgical facility that we offer. And they probably have, let's say, less time or less concern, or less time to express their concerns that is still there about the quality of care, and less time to express their discontent vis-à-vis the care we provide. And I think this is an interesting situation.
Yeah, no, I think you're right. And as we were discussing earlier, and as you agreed, it doesn't relieve the agency of the responsibility for making sure care is as good as possible, but understanding the context in which that care is being provided and people's reactions to it is very important, isn't it? And that context continues to be very dynamic.
Yeah, what was interesting is the research in my visit there last year was prompted by a series of intrusions in the hospital in Aden, leading to a number of closures and real questions about our ability to continue working in that environment. And what I found was something different. It was something that seemed to go against the advocacy effort to defend and protect the medical mission that should be sanctified and neutralized. And it was something that was very much grounded in the practicality of the medical work, something that you could identify very well as a user of medical services in the UK or in France, let's say, social demand, although I'm not too sure it makes sense in English, but the social demand by the people for good care, right? For good quality care. And I found particularly interesting the fact that our Yemeni colleagues, those were particularly at risk, not because there were so many real incidents and violence incidents, but because of the stress they were living under, were asking us as the employer to do something to address the situation, to recognize their discomfort in working in this situation. We had a couple of doctors who just left, who said, I can't stand that anymore. I need to go. I mean, this is getting too dangerous. I'm going to die in this hospital. A doctor told me, I've got 20% chances of dying in this hospital. So, of course, it doesn't match with the statistic recorded.
These are Yemeni doctors.
But that was his perception was that if things were going to continue that way, it would eventually die, And so, of course, that is very, very serious too. So how did they adapt to that? How would they cope with situations like this? And that was another interesting way of looking at things. Because, of course, they developed, without our knowledge, actually, some very drastic and dramatic coping mechanisms. First of which was, for instance, the tendency to refer patients for security reasons. I first entitled my visit report, the title that wasn't kept by ODI. It was No Patients, No Problems. Because it illustrates the fact that doctors were afraid of patients, and they would tend to basically get rid as many dangerous patients as they could. And they would identify dangerous patients with people from special tribes or from special social environments, and they would just deny them access to the hospital and send them to other hospitals, furthering the impression that the hospital was not for everybody, and then increasing the very risk that they were actually trying to mitigate in a way. And we had the same thing in Aden. Okay, many patients that were seen as too political were blocked at the gate by the teams, by the Yemeni team, because they didn't want the military to come in and get the patient in the premises, or the police. They knew somewhat that it was not totally in line with the MSF regulations, so they wouldn't tell us. They would do that sort of underground. And it revealed, it revealed the necessity for us to work on addressing this problem, to find out what were the root causes of these behaviors. That is not to be blamed, because I think they were, again, the first priority for these people is to survive, not to be harmed, and that was what they were doing when they acted in that way. And so, taking the issue seriously, We try to organize the care differently to further our negotiation capacities with different stakeholders. We would try to improve the quality of care. And we also launched an advocacy campaign through TV ads, through discussing with the authorities. Not that we believe that meetings will solve the problem, but that at least some awareness might help in securing the facilities.
No, very difficult and interesting situation, but it's good that, as you said, you tried to identify ways that you could actually adapt work and practices without actually increasing harm to their patients, which some of the negative coping strategies seem to do. I'm going to move over to Salim, over here on my left, far left again.